Piero, that was also a colleague when he was in CNAO. And I would especially like to thank him for his availability for the monthly seminar of HITRIplus. Piero graduated in medicine and surgery at the University of Rome in 2002, and he completed his specialization in radiotherapy in 2006 at the University of Milan. Then in 2007 and in 2009, he has completed his training in particle therapy in Japan at NIRS in Chiba. He had a very important and fundamental role in establishing the clinical operation with protons and carbon ions at CNAO. And now he is the head of the carbon ion program and the scientific director of MedAustron. His main interest is the clinical use of carbon ion radiotherapy, focusing on producing high-level evidence for established indications and exploring new potential application and synergies. He is also co-author of the ICRU report on carbon ions radiotherapy. And today he is going to talk about the first 2,200 patients treated with carbon ion at MedAustron. So I leave the floor to you, Piero, and again, thank you very much.
Thank you, Angelica. Thank you for the invitation, for the introduction, and also for the patients, because as you know, it's not always the easiest to reach me and get an answer. So thanks and apologies. So I will talk you about the first 200 patients that we have treated in MedAustron, or at least this was my initial intention. And I have no conflict of interest to disclose, but what I have to disclose is that and while preparing the talk, I realized that in these 200 patients, there were quite some diverse indication and things, so it would not have been possible in just 1 hour to go in detail into all the indications and body sites and tumors. And also, of course, we started carbon ion radiotherapy in MedAustron in July 2019. So for most of these patients, the follow-up is simply not enough to have a real reliable data in terms of outcome. So in reality, what you get today is, rather than the first 200 patients, some of the first 200 patients, and also some of the ongoing projects that I try to link with the real clinical need that you will see from the patients. So as said, we are treating in MedAustron carbon ions for clinical use since July 2019, and you are possibly all aware of, but allow me to repeat once again, it is one of the 4 centers in Europe providing carbon ion for patient treatment, and one of the 12 centers in the world providing carbon ion for patient treatments. So it is still a scarce resource. You might say that carbon ion radiotherapy is the most scarce resource in the whole field of oncology today. There is nothing else which is so difficult to get, but we are here in under the umbrella of the HITRIplus project, and the good thing is that one of the purpose of HITRIplus is to facilitate access to carbon ions. So just a reminder to all of you, there is so far yet not utilized the transnational access possibility of HITRIplus. If you have an interesting patient that you want to refer, take advantage of this. HITRIplus is not paying for the treatment of the patient themselves. This must be covered by other sources, but is paying for the travel cost and the accommodation cost of the doctor or the physicist or both that are referring the patient, plus for the additional research activities. So in case you want to refer a patient for carbon ion, just take advantage of this opportunity, because it will be a pity not to really use this money granted by European Commission and improve not the quality of the treatment, but at least the quality of the data and of the science we can get out of these treatments. So we have treated, as said, until October 2021, 200 carbon ion patients, and there are 3 main indications that have been treated, and this is no surprise. Head and neck. Of course, head and neck cancer is overall not a frequent cancer, but it's becoming more and more frequent. 90% of head and neck cancer is squamous cellular carcinoma, the well-known tumor that arises because of smoking and drinking and life habits. One could say with this word, with my Italian ear is still a bit funny, recreational habits, and only 10% and also the human papillomavirus plays a major role for squamous cellular carcinoma. So this is 90% of head and neck cancer, but we are focusing on the other 10%, all those tumors that are not squamous cellular and for which the conventional combination of surgery plus radiation plus chemotherapy does not have such good results as in the squamous cellular. So this 30%, 1/3 almost of our patients are salivary gland tumors, head and neck sarcoma, tumors originating from the teeth producing cells, so ameloblastoma, ameloblastic carcinoma, all these rare histologies. Then the classical indication we have is sarcoma, and of course sarcoma in the limb as a well-established treatment, which consists of surgery and chemotherapy for osteosarcoma and consists of radiation and surgery for soft tissue sarcoma. But so we are not treating those patients that do not need us. We are focusing on those sarcomas that are difficult to treat with the standard approach. So basically in the pelvis, in the thorax, in the spinal cord, in the head and neck. And radiation is another big part of the pie. Of course, if the patient failed the first course of radiation, you want to try something different, which can be high HIT plus hypofractionation. Then we have an interesting 10% of prostate. Well, if you look at Japanese centers, prostate is indication number 1. Now, as you might be aware of, carbon ion is reimbursed by the national system in Japan just for a few indications, among which non-squamous cellular head and neck cancer, yes, inoperable sarcoma again, but also for prostate cancer. And instead in Europe, saying that we treat prostate cancer with carbon ion looks like a heretic statement. But we have started a program about prostate cancer, especially high-risk prostate cancer, and I hope this may be the topic of one of the future talks. Will not really be something we discuss in depth today. So let's focus a bit on sarcoma, which really shows us many of the problems we are facing when dealing with carbon ion, especially because they can arise basically everywhere in the body. So there are, for the treatment of sarcoma, basically 2 different approaches, historical approaches that have been established by the pioneering centers. Pioneering centers means NIRS in Japan, which now, of course, is no longer called NIRS, is called QST, and Darmstadt, so GSI, and then Heidelberg in Germany. So the German approach was to do only mild hypofractionation, use basically a 3-gray RBE per fraction, and they mostly focused on skull base and vertebral spinal chordoma in chondrosarcoma. So in these tumors, that they could achieve very good results in Germany with 66 gray delivered at 5 or even at 6 fractions per week. So this is a little bit of a more gentle hypofractionation. Instead, in Japan, sarcoma treatment has evolved through several dose escalation trials to a 16 fraction approach over 4 weeks at 4 fractions per week, and a more aggressive hypofractionation. So the dose used in Japan for sarcoma is between 3.8 gray RBE and 4 or even sometimes 4.2. But this is using the Japanese radiobiological model. And this was a large part of the work we did in CNAO to convert the Japanese RBE based on the Kanai semi-empirical model and on the second step, the evolution, which is the modified MKM model, so that we could use our European RBE model, but still reproduce those data. So for us in MedAustron, using the local effect model, the Japanese approach, is 16 fraction, is 4 fractions per week, but the dose is increased by about 15 to 20%. So we go from 4.6 to 4.8 gray per fraction. This is really the same thing that we were doing and that you colleagues are still doing in CNAO. Let's start with a couple of examples of one of the most common indication we are treating in MedAustron, which is sacral chordoma. Sacral chordoma, as you know, is a rare disease, and there is at present an ongoing multicentric European prospective trial, which is the SACRO trial, in which we are trying to compare outcome in terms of toxicity and oncological outcomes of exclusive particle therapy versus radical surgery. And so far, this is recruiting very well, and we are quite happy that there seems to be confirmation that particle therapy is as good as surgery. So I'm just showing one example, which is not in the SACRO trial because was a bit more advanced than what would be accepted. This is a young man. He already had before a trauma because of his paragliding activity, and this trauma resulted somehow in a weakness and urinary disturbances. But then these urinary disturbances evolved into a complete incontinence, and he started to have pain, and they diagnosed a very large sacral chordoma. So sacral chordoma tend to be large. When you treat this disease, you are always saying, okay, my record is 2 liters, 3 liters. How many liters have you treated? But this was a huge one. You can see, most interesting, the whole sacrum, including S1, is completely involved by the tumor. So we treated this patient with this 73.6 gray RBE in 16 fraction of 4.6. This is the Japanese schedule translated for RBE, and this is the same thing that we were doing in CNAO. Now, the evolution in treatment of sacral chordoma, if you want, has been, at least my personal evolution. I had the impression that in CNAO we were maybe too delicate. Sometimes we were using 4.4 gray because we were afraid of sacral insufficiency fracture, which is absolutely legitimate to be afraid of, but I'm afraid it is not the optimal. So we are increasing a bit the prescription. We are now considering 73.6 as standard for this disease, and we are also trying to increase a bit the allowed dose to the rectum in order to really reproduce the good Japanese data. You can see these very large treatment fields. So this is another topic which is common to the European carbon ion facilities, and is not really such a big issue in the Asian carbon ion facility. We all have experienced that at the beginning, delivery of carbon ion radiotherapy is somewhat slow, and then physicists work hard on the accelerator optimization. Sometimes they're trying to explain us what they are doing. It's not always easy to understand, but of course, reducing the time to do the washing of the magnets, etc., and eventually one day multi-energy extraction. So you go from very slow to fast to very fast. Right now, we know that Heidelberg has almost reached the maximum you can extract from this machine design. Now is always also almost there, but in MedAustron we hope to be as fast as Heidelberg and now possibly by the end of next year. So for us there is an issue about how big can the volume be. This patient took almost 1 hour of being on time for treatment, but he was young, he was very motivated and could be treated. He had already a quite nice symptomatic response during the treatment, and he had no new toxicity. But what is quite interesting, he had a complete resolution of the urinary incontinence and the major improvement in the pain. He was really almost lying in bed because of pain despite maximum dose of opioids, and after 6 months he was back to paragliding again, and he was wearing a diaper, and then he could have a normal life, including a normal sexual life in a 41 years old man. And there was a major dimensional tumor response. You see in red the tumor before treatment, and then you see in blue the tumor 6 months after treatment. So this is an interesting case because it really shows that we are convinced, and we continue to be convinced that the high LET of carbon ion can have a significant value in sarcomas, yes, not necessarily in all sarcomas. So if we design a trial to compare carbon ion versus protons, well, the key question is, how do we select this patient? If we just compare for all sacral chordomas, we may dilute the population, and then maybe the advantage is not so evident if the advantage exists, not because it doesn't exist, but because there are a lot of patients that can be treated equally well by both modalities. So this is a topic which is quite important in new modern design of particle therapy trials. How do we enrich the population so that we create the best condition to really detect the difference and the advantage? I give you another example of a patient that we have treated. This was, as said, chordoma. So for chordoma, once again, we in CNAO, in the initial phase in which we were translating Japanese approach, we were saying 4.4 or 4.6 times 16, and the initial data, we were a bit scared about toxicity, so we said, okay, 4.4 should be the default, and 4.6 when you can afford to escalate. But now the data we are seeing are still preliminary, but the sacro data and the other data colleagues in now have analyzed are very good, but maybe somewhat less than those reported by the Japanese centers. So in Austria and MedAustron, our new approach is to say no, that the default dose for sacral chordoma is 73.6 at 4.6 gray per fraction. Pelvic osteosarcoma is a much harder nut to crack than chondrosarcoma, and you know that reported survival of patients with inoperable or anyway non-operated osteosarcoma is really dismal. Only a few pediatric patients can survive to 5 years with aggressive photostereotactic radiotherapy, but in adults, non-operated osteosarcoma survival at 5 years is basically 0%. This was a young girl that started with pain in the gluteus and was diagnosed with high-grade osteosarcoma. She started chemotherapy as is standard in osteosarcoma according to the established protocols, and could not achieve a major dimensional response. So they suggested to the patient amputation with hemipelvectomy with permanent colon and urostoma, which she declined, and we treated according to again Japanese schedule after translation for RBE with carbon ion radiotherapy as exclusive local treatment. Here it was 4.8 for osteosarcoma. We all agree use the maximum, and this 4.8 is our translation of the Japanese 4.4. So 4.8 times 16 fraction to a total of 76.8. You may see the nice gradient toward the rectum and sigmoid colon, and you might see the selective nerve sparing, on which I will tell you more in a few minutes. And you can see the quite nice coverage of the target. What is interesting is that we are really trying. I mean, you all have seen the slide from Japanese colleagues, especially from Dr. Kamada, showing the young girl with chondrosarcoma that after 1 year was pregnant and could successfully carry out 2 pregnancies, and that's 2 beautiful babies. So we said, okay, if they can do that, why shouldn't we be able to do the same? So in female patients of reproductive age, we are going to a great extent to spare completely one of the ovaries. and to save those to the uterus. So you can see this very low 3 gray RB isodose, which is not touching the ovaries. So we went for a radical treatment to this large pelvic tumor with ovarian sparing dose distribution. This is another quite successful example and good result. She had only minimal toxicity, no gastrointestinal, no genitourinary. Being a young and fit patient, it's also, of course, good for her muscle and bone function. But at the end of treatment, she only complained of fatigue G1. Then after treatment, because of osteosarcoma, of course, we tried to use carbon as a surrogate for surgery, but she received the additional chemotherapy, which is considered standard for osteosarcoma. And we have the first follow-up at 3 months, which just shows a dimensional stability before carbon, and at 3 months, there is no change in the shape of this tumor. Then we have another follow-up at 6 months with PET-CT, and again, you see basically that the morphology is not changed. But what is quite nice, well, again, this hyperostosis was all tumor, but as you could see in the MRI and in the initial PET, also the soft tissue component was also sarcoma. So this was all stable at 6 months, basically no change, but there was a complete metabolic response. So this is the PET scan. So there was a lot of FDG heavy tissue of highly metabolic tumor cells that were reproducing. You may observe here in front that this high FDG uptake is really the reason why the surgeon were not pushing for surgery, because they said, okay, that this is a major blood vessel infiltration. So even an hemipelvectomy without sacrificing the limb, we are not sure if we are able to do. Maybe we realize that the blood vessels are so infiltrated that we have to do the major procedure with amputation. And so that's why the discussion was relatively easy. The patient didn't want to undergo surgery, and the surgeon was not so willing. Same disease without this anterior horn maybe would have gone to surgery. Then, of course, it's a question if it would have been better or worse. So in this case, I said, we are super happy because there is complete metabolic response at 6 months. You see the FDG uptake is completely gone. So there is no macroscopic metabolically active tissue. And at 12 months, she did a further control in which the patient comes from Slovakia. The radiologist was, according to my opinion, a bit too optimistic, but he wrote no evidence of disease. Well, no evidence of disease is, of course, not true. There is still this stable tissue, but it has MRI a signal suggestive of necrotic tissue and no active tumor. It has complete metabolic response. The patient has no toxicity and is doing quite well. So these are two examples of what we are doing. We are treating a lot of this pelvic tumor. They are referred. Doesn't mean that we cannot also treat thoracic wall or shoulder. Yes, but somehow the pelvis is the area in which surgeons are more willing to refer the patient. So I said, for these patients, we are at present investigating two issues. One is nerve roots, and the other is rectum and sigmoid colon. For nerve roots, we know quite well that there is a dose dependency. If you give too much dose to a long stretch of nerves, then you may end up with the very unpleasant late radiation-induced neuropathy. We all have seen patients with severe painful neuropathy because of radiation, and it is a major reduction in quality of life. So these patients sometimes must be treated invasively with infiltration of anesthetics directly in the nerve roots. as they come out of the spinal cord. Some of them get a catheter with a pump releasing anestheticum drop by drop. Eventually, you can control the pain, but you can have loss of function, so motory and sensory function. So it is a big issue. And when we are treating this large tumor involving the sacrum with these high doses, the risk of these severe unwanted side effects is in the order of magnitude of 10 to 15% in the reported series. So what we are trying to do in MedAustron is a bit a continuation of the work we started in CNAO, and we are saying basically now we have spot scanning. We have a small spot because carbon, just because of its physical nature, has smaller spots and sharper gradient. So we may try to selectively spare the nerves. So this, of course, is a process that consists of 3 steps. Step number 1, you have to contour the nerves. And not all the colleagues and not all the technicians are super happy about this. Of course, it is time consuming and can be a bit boring, and you don't always see them. But by a mix of time and patience and experience and looking at multiple orientation, coronal and sagittal and CT and MRI, in the end, I think you don't really have to follow published guidelines that simply say put in a very big volume where the nerves must be, but you can be more ambitious and contour the single nerve roots. This is what we are trying to do. And if you look at surgical papers, they are not so small. Huh? This is an open pelvis, and these are the nerve roots as the surgeon would see them. So if the surgeon can see them, my point is we can also see them. So we are really trying internally to convince everyone that it's not a waste of time to invest those additional 10 to 15 minutes to contour the nerve roots, all the nerve roots in the sacrum. And when you have them, then you can, thanks to the sharp penumbra and spot scanning, you can spare them. Well, of course, doesn't mean they don't get those. You just need a little bit of sparing. What we are trying to do is in treatment where the prescription dose in the order of 73 to 76, we are trying to keep the nerve roots at less than 69, 68, or at least the nerve roots that are visible are not macroscopically infiltrated by the tumor. And if we have to exceed them, we try to limit the stretch of nerve which is treated with more than 69. So we know there is a dose volume effect. So not only the dose, but also how long. If you treat 6 centimeters of a nerve root, the risk that you will have neuropathy is much higher than if you treat half a centimeter. So this looks nice, but of course then they always ask us, okay, do you really believe you are delivering that dose, or it's only a nice plan, but in reality it will not be so good at all? Well, of course, this is a topic we are aware of. So once again, with prescription from 70 to 77, we try to keep the nerve dose to less than 69. So we are doing some robustness analysis. And yes, of course, there is somewhat a degradation of this beautiful plan. So here you see that the cranial part of the yellow nerve root is inside the brown GTV. So there we are not trying to spare. We say, yes, this is really too high a risk of infiltration there, you cannot afford. But the part of the nerve roots which is outside of the GTV, we are trying to spare. And in the left, there is the nominal plan. And then here you see 2 plane recomputed on 2 control CT. So we are routinely doing control CT. We are recomputing this plan. You lose something, but you don't lose everything. There is a good reproducibility of nerve sparing. Of course, here the debate you all understand is how big a hole you accept. If you make a very big hole, it is more robust. If you make a smaller hole, it is less robust. We are discussing each of these cases, and I don't know what is the best compromise. But the message is our nerve sparing is not something that exists only in the nominal plan and then is completely lost. Part of it is lost, but it is still worthwhile because we don't have hot spots and we still have a sparing of the small structure. So of course, question is, does it work? Will this nerve sparing eventually result in less late painful neuropathy in this patient? And we still don't know. I apologize, this 25 patient come from an old slide. At present, we have more than 40 of these patients treated in high dose sarcoma in the pelvis, but neuropathy is a late event. Typically, it occurs 2 years after the end of radiation, and we have reports of particle therapy, radiotherapy induced neuropathy with protons that first arose 7 years after the end of treatment. This is from MGH. So we don't know if we are able to spare the clinical unwanted side effects. It might be that in the end, this selective sparing is not so effective because it's not the nerve itself, but is the blood flow in the area. Well, point is, the attempt is not so difficult, and the future will tell if it was worthwhile or not. There is another issue, and that this is only trying to take care of the neuropathic component of pelvic pain. But we know that there are patients that after a radical particle therapy in the pelvis develop pelvic pain, not because of damage to the nerve, but because of damage to the bone. So the topic of sacral insufficiency fracture is another very hot topic. Again, if you listen to Dr. Kamada, it tells you that 100% of patients treated with this dose of carbon ion in the sacrum will develop sacral insufficiency fracture. And the point is not really to get a radiological diagnosis of sacral insufficiency fracture. The point is to understand how many of these will be painful and how many of these will be severely painful and how many of these will be painful in such a way that is disabling for the patient. And recently the colleagues from Japan have analyzed the dose volume response of sacral bone, but here you don't have much possibility to spare because that is the target. So it's just in the end understanding if we are better than surgery or not, and this is the purpose of the ongoing sacral trial, in which the main issue was really this sacral insufficiency fracture and how to score them according to symptoms and not according to radiology. Another topic which I think is interesting in terms of pelvic irradiation of sarcoma is that the constraints for the rectum and the sigmoid colon. So these constraints again is a work we started in CNAU, and then somehow we are continuing to do in MedAustron. There is also a nice publication by CNAU colleagues with Choi as first author, looking at those to the rectum and toxicity. What we are doing in MedAustron is a little bit more aggressive than what we were doing in CNAU in the beginning, but also colleagues in CNAU are moving in this direction. So these are the numbers when you treat carbon ion 16 fractions, be it a sarcoma, be it a pelvic recurrence of a rectal cancer or even of a aggressive gynecological cancer, or be it a aggressive recurrence of prostate cancer. We accept 1 cubic centimeter of rectum and sigmoid colon to go to 66 gray RB, 5 centimeter to go to 63, and 10 to go to 55. Well, as you realize when you do this plan, the 5 and 10 cc are very, very easy to respect. That the issue is just that the high dose to 1 cc. And in MedAustron, we are trying to make the most of cooperation with surgeons and urologists. So even more than we did in CNAU, we are taking advantage of spatial insertion. We are trying to separate the rectum from the target by putting some material. This now is done by our colleagues in the surgical department close by with laparoscopic approach. In 2 days, the patient is ready for simulation and immobilization. It's reabsorbable, and in comparison with the technique we had developed in CNAU, it is a slightly different approach. So the surgeon will use reabsorbable compatible material that does not need the opening of the peritoneum. So when we are treating a sacral and presacral tumor in the retroperitoneal area, we prefer now not to open the peritoneum and avoid any risk of contamination. In Pavia, we were opening and closing the peritoneum, but the surgical technique was thought out so that there was no risk, because a part of the peritoneum was resected and the other was closed and suction was applied. So it was in the end safe, but I would say a bit more demanding on the surgeon. This one is safe and less demanding on the surgeon. So about rectum, we have treated 69 patients out of the 200 carbon ion patients that had a disease in the pelvis, in which we applied the high dose, and this high dose was close to the rectum. They were 49 sarcoma and recurrent rectal cancer and 20 prostate. But from our point of view now, it's really not relevant. The point is that it's already some patient, and we have seen no rectal toxicity at all. Nothing, zero. Of course, follow-up is only 10 months. Let's wait and see if it's still the same. Now we also had very low rectal toxicity, but maybe here I have even less. So the reason I believe is that we are doing, it's more labor intense, but we are doing more control CT. We are routinely doing control CT for recalculation of rectum. So it is more time, but in the end it is worthwhile, because when we see higher dose, we replan. This also, of course, was done in CNAO, but not to such an extent. Here we do that for each and every patient, and the first one is after 1 week. And if the first one is not good, then we do a second one, so twice over the 4 weeks, and maybe the patient got 2 replanning. Result is that we don't see any rectal toxicity. We have had not a single patient with tenesmus, with burning, with bleeding. So of course, the next step is to ask ourselves, are we too conservative on the rectum? We know that rectal sparing can lead to tumor recurrence, but it's very, very hard to escalate and establish constraint. So far, we are trying to solve the issue with spacers. At one point, we will have to consider if for selected cases in which, despite everything else, the target coverage is still not adequate, we shouldn't consider prospectively to escalate the dose to the rectum, because right now we really don't see any rectal toxicity at all. Now, you have seen some large tumors. Sarcoma in the pelvis tend to be large. Also rectal recurrence can be large, and come another topic which really we are all aware of, but is hopefully something in which now we will be able to do more than in the past. And this is the fact that carbon ion is not high LET radiation. As we are all aware of, carbon ion is a mix of high LET and low LET. If you look, if you use oxygen, then a reasonably large SOBP, so oxygen here is the blue line, a reasonably large SOBP of, well, not much, but 4 centimeters, and typically our targets are much bigger than that. But even 4 centimeters, you need to use oxygen to have all high LET with just one single SOBP with one beam direction. If you use carbon ions, the red line, then even a small 4 centimeter SOBP when you treat with one beam gets half of the dose by mainly low LET, just because of the mix of high and low LET and the combination of those in the break peak and those in the plateau. Is it relevant? Well, there is more and more evidence showing that it is relevant. The initial evidence I was always quoting is in Japanese experience, large sarcoma fare much worse than a small sarcoma. Look at the local control probability of osteosarcoma larger than half a liter. really dismal, and look how nicely they could control smaller. And of course, the objection here is, yes, of course, small tumor easy to treat, large tumor difficult to treat. And my gut feeling was that, yes, this was not really the full story. The full story was that small tumor gets a lot of high LET, large tumor does not get a lot of high LET, but this was just a matter of opinion and debate. But we are starting to collect more and more confirmation that the role of LET in the suboptimal control of large sarcoma is relevant. Well, not only of large sarcoma, in the recurrence and failure to achieve local control with carbon ion. So we have the paper from Hagiwara that analyzed local recurrence of pancreatic cancer treated with carbon, and he could demonstrate that underdose in terms of RB weighted dose was not so relevant. There was no significance. The area where the recurrence did develop had not received less RB weighted dose. On the other hand, the areas where the recurrence did develop had, in a very significant way, P0006, had received a lower LET. So the part that is not really treated with carbon in the simple-minded sense of high LET radiation has a higher risk of recurring, and this is for pancreatic cancer. And then comes the paper from Matsumoto, you see all in the past 2 years, focusing on chondrosarcomas. And you see in red are the patients that did recur, and in black, the patient that did not recur. And here in the y-axis, you have the tumor volume that was treated with a low dose averaged LET, not dose, but dose averaged LET. So we trust our RBE model in saying it's the same if you give a little high LET dose or a lot of low LET dose, but no, it's not the same. If you give to a large portion of the tumor a lot of low LET dose, then you could as well treat with protons, then you don't have the advantage of carbon. And the red circles are all in the upper part of the graph. So if you are able to treat most of the tumor with high LET, then you have much higher probability of control and less recurrence. And then comes the paper from Knau colleagues in sacral chordoma. And yes, the patient that did have a recurrence, in the recurrence had lower dose average LET. So a lot of clinical data is now confirming that this is clinically relevant, that we should make sure we put the high LET where we want. And again, if you treat a small target, the green line, you see that the profile of the physical absorbed dose, which is of course tapered, because toward the end of a single beam, you have higher LET and higher RB. And then you see, again, in green for the small target and in red for the large target, the dose average LET itself. So a negligible part of the big target is getting the high LET. This we all know, but what is important is that finally maybe we can act on this knowledge and do things in a different way, in a better way. So this again reinforces the message. Big target does not receive high LET. Now, step one is we are formally analyzing the value of coming from different angles. This, if you want, is really the practical know-how. When we tell, yes, you don't really learn how to use in an optimal way carbon ion simply by reading books and articles. Well, this is so far something that has not found its way in book and articles. It is much more important for carbon to have multiple beam angles. So far so that we are basically trying, not always, but almost always, to add the contralateral beam, even in lateralized head and neck tumor. Because if you come only from one side, then part of the tumor gets the high LET and part does not. Needless to say, optimal approach is two opposed beams, and this is practical knowledge from, for example, Niels and Chiba. They have at least 1/3 of the dose for the big target coming from the contralateral. So 1/3 it means 3 fractions out of 16, 3 of 9, and then for the 7 of the boost, they come all homolateral and at 90 degrees. So this component, this contralateral component is extremely important, not only for robustness and range uncertainties in protons. Well, in protons, you can say, you know what, I prefer to spare completely, and I accept a little bit less uncertainty and range issues, but I come only from one side. In carbon, it's possibly not a good idea to come only from one side. The second thing we are doing, we are in a clinical environment trying to really analyze the LET distribution that we receive when we don't act in any way and we simply let the optimizer do its work. And as we all know, but one thing is knowing, one thing is seeing in practice. Unfortunately, high LET is out of the target and inside the organ at risk. Look at this large sacral chordoma. It's the same patient I showed you before. So results is very good. We are happy, but the high LET is out of the tumor and at the border with the rectum, not really where you want it. This plan is what we could optimize and deliver to the patient. And this plan is another plan which is just as good. Well, it's not true, it's just as good. Look at the 70% isodose. The 70% isodose is the bright yellow. This bright yellow in the original plan we optimized was not reaching in the gluteal muscle. And in this new plan, it is reaching in the gluteal muscle. But honestly, number one, we don't really care so much about the gluteal muscle. And number two, the RBE in the entrance plateau is very debatable. But look at the LET of the original plan and of the new optimized plan. So finally, we have the support also of vendors and TPS vendors to integrate LET optimization in clinical workflow. And I think this would be a major step forward when we will be able to put the LET where we want, even paying a small price in terms of conformality of RBE weighted dose. For the sake of time, we skip this, that will deserve something more in the future. Now, as I said, 200 patients and everything was a bit too much, but I'm now realizing that I've used almost all the time. So I asked to Angelica if we should stop with the pelvis and leave the head and neck for a future occasion so that we have some time for questions.
Yeah, I think it's a good idea, Piero. We would really be happy to have you another time for the head and neck. So just please, you can finish with the this part.
As you see that there is still quite a lot, so we will not be able to do this in the next 5 minutes. I always get carried away by my enthusiasm for the topic. So let's stop with half of the presentation and please, I'm open for questions.
Yes, thank you, Piero. And in the meanwhile, I ask to all the audience to switch on the camera for the photo of the seminar. And in the meanwhile, if you have questions, you can write down in the chat or you can also ask directly to Piero.
Can you, Piero, just stop sharing?
So I can, if I find that. Yes, here it is.
So that just for the photo, then you can, yes.
Oh, photo, yes.
Okay. In the meanwhile, Piero, there is a comment actually in the chat. Valentina Zambrano wrote that interesting, and I agree it is useful contouring nerves. It is what should be done. Perhaps could it be useful to automatically segment nerve roots with ML or similar algorithms? It would benefit the schedule and the overall long-term hospital planification. Do you have anything to add, Piero?
I agree. I have nothing to add. I only agree. What we are living in our daily practice is a little bit like the guy that is trying to harvest the cornfields and say he has no time to stop and sharpen the sight. So at the moment, and they are saying we don't have time to really commission those automatic contouring algorithm. In the long run, it's not a very clever approach. We may gain, but if you have to put to invest manpower now, we don't have it. So the automatic contouring, great if it can happen reliably, and you have to invest a bit. And I agree in principle, but in practice, I'm not doing it.
Yeah, okay. Let's see in the future. Why not? Any other question or any other comment from the audience?
While you're reading the next one, Angelica, can everybody please turn on your video so we can take our Zoom photo, please? Thank you.
Okay, Petya is taking care.
So there is another question from Martina Palkovic. She asked if we treat with mixed carbon and protons. And yes, answer is yes, we do. For example, in head and neck adenoid cystic carcinoma, which, as you know, is a very neurotropic tumor, so it tends to grow along the nerves. And we have quite a few patients in which the surgeon takes out everything and say they've done a macroscopic resection. But then when you do the immobilization, you realize that the tumor was in the face, in the parotid loggia, let's say, but there was a macroscopic infiltration in the nerve, and you have inside the skull macroscopic tumor that was overlooked by the surgeon. So this is quite common, unfortunately. So you have a small macroscopic disease where you would need high lithium carbon, and a large postoperative bed where you are afraid of toxicity. So that's a classical example we treat with proton plus carbon boost, and several others in which there is a large surgery and only a small macroscopic residual disease. We treat proton and carbon boost. We have a second category in which we use carbon boost, and this is what we call the runaway train. So a patient that is treated with protons, and you do a control during treatment, and you realize that during treatment, not after the first fraction, but after maybe 2 weeks of proton, where you expect at least stability, the tumor is growing despite radiation. So these patients are at very, very bad prognosis, and sometimes we try to salvage this progression under treatment with just a few, typically three carbon ion boost to the progressing tumor. For example, we had a gentleman with a meningioma, which is not really a candidate for carbon ion normally, but this large extracranial meningioma growing in the orbit was growing during treatment with protons despite the treatment, and so we delivered. And this is another topic for further development, because in this gentleman, we treated for 3 times the normal 2 gray of protons, and then concomitant boost with 5 gray RB of carbon. But there is no TPS that calculates the RB of a simultaneous carbon and proton treatment. So we accepted that this was wrong, but it was, and we could eventually control this. So runaway train, treating the patient that is growing under treatment with carbon, and this would greatly benefit from a improvement in TPS and RBE calculation. Number 3 is just a wish. We are not able to do that, but we would like in the future in those cases not to do some fraction with proton and some fraction with carbons. We would love to do in a single fraction carbon in the center and proton in the much larger volume outside. This would by itself bring LET, high LET into the part where we want it, because the outer rim of CTV1 is treated with protons. This would be very elegant, of course, demanding in terms of planning and accelerators.
Okay, thank you, Piero. And in the meanwhile, we have 3 other questions. One is from Mihai. Thanks a lot for the interesting overview. It may sound a very administrative question, but I wonder what is the access protocol for an European patient? Is it covered by a standard medical insurance?
Oh no, it's a very relevant question. Unfortunately, we have to deal with this. So all member states of the European community plus a couple of others that access to this larger Schengen. So Switzerland, yes, UK no longer, Norway no, Sweden of course yes. So all these states that can access the S2 treatments, and then it is reimbursed by the national health system. Of course, it is reimbursed after the case is accepted. So for example, we have treated quite a few patients from Hungary. Patient is referred from the surgeon. We agree, we write a letter saying there is an indication and explain in detail why. So this is the letter from the Austrian radiation oncologist. The Hungarian surgeon also writes a letter saying patient must go abroad to receive carbon ion radiotherapy, but then before this is approved in Hungary, it can last up to 3 months. And we have patients that were accepted, and when they come 3 months after, the situation is different. In other countries, it is much faster. For example, Slovenia, typically in a couple of weeks, you have yes or no, but at least you have an answer. So European patients have access to carbon ion centers in Italy, Germany, and Europe within S2, but they need authorization from the national health system.
Yes, thank you, Piero. Then Ivan, thank you for the very informative presentation. I'm making part of the CIST team in CERN, and currently I am working on an algorithm based on neural networks machine learning that would be able to make a preliminary selection of patients suitable for radon therapy. We are working with the European Network of Cancer Register datasets, and at the moment I'm trying to define and quantify attributes from cancer patients dataset. So I would like to hear from you, what are the conditions, patients attributes that you take into account when deciding on patient suitability for radon therapy?
This is another very important question, and I will give you my answer, but before, allow me a very short comment. Personally, I am a bit skeptical that an artificial intelligence-based system can work better than a doctor in this. But this doesn't mean that there is not a value in this. And the value in this is that paradoxically, in our society, they trust me to deliver a dose that can make a hole in a rectum or in a brain. So for that, they trust me, but they don't trust me to say this patient must come to me. They say, oh, no, you just want to extract the money from the patient. So even if we may have different opinions in terms of will the network, the neural network or the faculty system do a better job or a worse job than a doctor, the very strong point is that it will be an unbiased objective evaluation without any possible vested interest. So there is really something in that. The characteristic for me are histologies that are not well controlled by conventional radiotherapy, including protons. And this we can make a list, but very shortly, osteosarcoma, soft tissue sarcoma with the exception of Ewing and rhabdo, salivary gland, high-grade salivary gland tumor, melanoma, mucosal melanoma, recurrent rectal cancer, and pancreatic adenocarcinoma are the first that come to mind. Second topic, macroscopic, present inoperable or non-resectable disease. Third topic, bulky disease, bigger than a given threshold, which is variable according to body site. And fourth would be no metastasis, with the exception of very selected case like stable lung lesion from adenoid cystic carcinoma.
Yeah, thank you. And then another one from Marco Puglia. So, would some kind of strongly non-uniform single field planning be of help? I mean, many inhomogeneous fields whose sum is uniform in dose and or dose weighted LAT.
Basically, you treat half a tumor with one field, the other half with the other, and then you have smaller tumors in which our LET is higher, and you can make it extreme.
I completely share your point of view. This is what I am thinking. Block one beam so that the high LET goes inside the tumor. But people from TPS software, one for all, Lars Glimelius and Eric Traneus, they tell me, you think you are smarter than our algorithms, but you are not. Tell us what you want in terms of LET distribution, and we will find a way to achieve it better than your simple idea. So I share your point of view. They claim they can do better. And as we are on the topic, and I hope there will be occasion to spend more time on that. It was partially in the non-shown part of my presentation. Most of the work so far has been on dose averaged LET. And as you know, the relationship between LET and RBE is non-linear and bell-shaped. So in a way, I'm convinced that dose averaged LET is not the physical quantity we should focus on. And after some troubled sleep and theoretical thought, I came out with the idea that the relevant quantity is the amount of physical dose given above a given threshold of LET. So this is better because it really does not penalize the very high LET, which has a lower B. Yes, lower B, but is very robust against the radioresistant component. And what we are trying to do is to focus on this other parameter. And we discovered that this parameter was already imagined as important by proton people, and they call it dirty dose. So dirty dose is the percentage of physical dose given at a threshold higher than X. And we are now trying to define the optimal value of this X by comparing the dirty dose distribution in small and large sarcomas. And we are trying to also extracting this from clinical data. We are trying to understand which percentage of the tumor volume must get which percentage of dose as dirty. So this means we are trying to find a quantitative answer to the qualitative statement that most of the tumor should get enough dose with high LET. So what does most, enough, and high mean? We are trying to extract from clinical data. I was hoping to present a bit more today, but I was just talking too much in the initial part. So possibly in the next occasion.
Yeah, surely, Piero. And then Martina, answer you back. Thank you for your answer. And are there many patients treated with mixed photon carbon ion therapy as well?
At the moment, not many, maybe less than 10%, but this is an area where we would like to expand. Again, this could be another topic for another seminar. There is a completely untapped potential, and this is using carbon ion for high incidence tumor. You wouldn't normally think about for carbon ion, not because of the high RBE, but because of the possibility of inducing faster and better reoxygenation. So if we want to explore the possibility of anticipated carbon boost for bulky hypoxic squamous cellular head and neck, bulky hypoxic cervix cancer, bulky hypoxic lung tumor, this would open the door to many mixed beam treatments.
Okay, and there is the answer back from Ivan. Thank you for your answer. As for the AI algorithm we are developing, it is suggestion-oriented, not a decision-making algorithm. That should help doctors narrow down list of potential candidates for hadron therapy, not make a unilateral decision on their behalf. And I agree with you that decision like this shouldn't be left to any algorithm.
No, but the algorithm would still be a very nice for what you are saying, but also in the real world to support the indication for the third party that must fork out the check.
Okay, thank you, Piero. I don't see any other question. I just would like to remind, as you did for the TNA access, that you can go, I will share the screen. You can go to the HITRIplus web page, You can see it. There is a dedicated page on translational access where you can apply for the clinical access, as Piero has already described you, for the medical doctors who would like to follow, medical doctor or physicians or physicists or whatever, want to follow the patients during the treatment and to learn, let's say, in the field what hadron therapy is. And then we have also the research access. So researchers who want to apply for beam access with the hadrons like carbon ions, they can just apply here at the website. So I guess this is all. I don't see any other question. I really would like to thank you, Piero. And we have already taken notice on the fact that you will take another seminar in the next future. So thank you really for your availability and your enthusiasm for these subjects. So I wish a nice evening to everybody.
Thank you very
And
much.
see you.
Thank you, Piero.
Thanks a lot.
For the next seminar.
We are holding
Bye.
on to your promise for the next seminar, Piero.
Yes, yes. Bye, bye, bye.
Ciao a tutti.
Ciao, ciao.
Ciao.